best panels I've seen. I think, you know, and how many of you were at HIMSS last week? So HIMSS was great. There was no panel that good at HIMSS.
You missed mine.
Oh, shit. And so, no, that was, congratulations, Bambi. That was a really good a bunch of people you put together. My name is Mark Goldstein, and what I'm here to do today is really introduce two really great early stage companies that are going to be doing their pitch. Before that, Bambi, you said I have my 5 minutes, so I'm going to give you my 5 minutes. I'm an early stage, primarily healthcare investor. I've been a fan of and friend of Vator's for years and years. You know what the first four of these panels, this is going to be a great tradition. I just felt like what I saw a minute or so ago. This is something that we're going to be here for years and years for our 4-part series every year. My background actually wasn't healthcare. So my background was retail, and I've been in fintech. And one of the things that I started was a company called Blue Light, and this was in the .com. So Blue Light was a spinoff of Kmart. So, and as I was thinking about the panel just now, I just said, oh my God, Kmart is the ER. Kmart is no different from the ER. So everything that was wrong, obviously everything was wrong with Kmart. There is no more, for all practical purposes, there are no more Kmarts. But when I took the job, and the idea was to introduce the internet and introduce sort of the, you know, really what were at the time Gen X and millennials to Kmart. Kmart was a mess, but it was the 3rd largest retailer in the world. It's now gone. The experience that we all have when walking into a Kmart is really not that different from the experience we all have when we walk into an ER. It's pretty much the same linoleum floor. And it's the same experience. It's looking around and you're saying, oh my God, can you believe I'm here? And it's, you know, it's basically between, it's no different from the leaky ceilings. And while every hospital is putting their billions and billions of dollars in, this is the opportunity we see. We talked about the opportunity of what Amazon. Well, the opportunity here is basically we're all moving away from Kmart, and the opportunity are these clinics. An amazing company that I had the opportunity to invest in a few years ago is called Dr. Consulta. And I don't know if any of you know who Dr. Consulta is. It's the largest network of clinics in the world, and they're based in Brazil. They're primarily in Sao Paulo. And I invested with the Walton family, because the Walton family feels that Dr. Consulta is going to be the largest next retailer that the world will see. They have 250 clinics in Brazil, millions of patients right now. And Brazil is wonderful. Unlike the US, Brazil has this new middle class. They have traditional hospitals. They have all these people that now really can't get medical care. And these clinics are able to open up. They're opening up in strip malls all around major cities in Brazil. And the middle class is going in there, and they don't even know their hospital. They are so excited to be able to go into a clinic and to basically get the experience that they would get in a retail store. And so I invite all of you to take a look at what Dr. Consulta is doing. I'm also an investor in Forward. So part of me is, I think Dr. Consulta is doing a lot of what Forward is doing, but they're doing it for a middle or a lower middle class. And they're doing it not just a pure, Forward is amazing. It is very, you know, it is so San Francisco. And Oren is an amazing entrepreneur, but it's super technology. And Dr. Consulta is more people. And a lot of, you know, most people would rather deal with a person first and a technology second, as opposed to going to Forward, you're dealing with technology first and then people second. So I think that's something worth considering. I've made about 40 investments in healthcare. Some are Circle Medical, which is a small clinic practice in San Francisco. Another one is called Orchestra One, which is enabling clinics to better take payment from their patients and to collect basically insurance payments. This clinic model is the model. This is the future, and I think collectively we're all excited about that. It is the sort of the Kmart, you know, the ER is the Kmart, and you know, really with that, we have two companies today. We're going to start with Tracy that are doing some very interesting things. What Tracy is doing, and she's going to talk about it, what she's doing. It's very simple. She's making it really easy for 2 minutes. Great. She makes it real easy for patients to find the very best doctor they can find closest to them. And with that, I'm going to hand off to Tracy. Oh, you guys. Okay. All right. Well, we're going to do a little switch here. I'm going to hand it off to Ian. Ian is built technology to enable clinics to do a lot of what it is we're really excited about clinics can do. If it wasn't for this, the problem is, you know, Kmart had these mainframes. Hospitals have these mainframes. We don't need mainframes anymore because we have these great phones. And what Ian is doing is a perfect example of that company, that type of company. So there it is. But the only way clinics work is that they don't require mainframes. They can use phones. They can use cloud. And Ian is a perfect example of a company that's doing some of that.
Well, thank you very much. And thanks to Vator and to HP for the wonderful opportunity to speak with you guys today. As Mark said, my name is Ian Bork, and I'm the CEO and co-founder at Pathos Health, and we are empowering patients from the decisions that they make through their outcomes. So we all know underengaged patients cost the healthcare system billions annually through increased readmission, lack of adherence to care and medication plans, through decreased satisfaction and decreased experience scores. Engagement today, so 85% of people are forgetting their doctor's post-care instructions by the time they leave the front door of the medical office. 50% of people can't explain their condition to a friend or a loved one, and less than 10% of decisions that happen today are considered informed. So what this means is poor outcomes and increased costs to the system to administer the care. Shared decision-making is an emergent method of addressing this engagement gap. So shared decision-making takes place when a doctor and a patient talk about patient preferences, treatment options, and weigh this against evidence-based guidelines to build a personalized care plan. Shared decision-making is reimbursable under the value-based care model and has been shown to provide greater than 20% savings to the system when implemented appropriately. Pathos Health has built a shared decision-making and engagement platform, and I'd love to show you what we've built.
Imagine owning and understanding your treatment journey. Introducing Pathos Health, an interactive way for doctors to engage patients throughout their journey. Using high-quality 3D models created in collaboration with Stanford University, we create an immersive experience to improve patient health literacy. Pathos changes the way patients and doctors work together to make the best decisions for the patient. So, how does Pathos work? Here we have Jane, who is having pain in her wrist, so she visits her doctor. The doctor diagnoses Jane with carpal tunnel syndrome, and with Pathos, the doctor shows Jane the condition in 3D, saves notes explaining what each treatment option may entail, and records drawings of the visual model so she better understands her condition and recovery journey. With the Pathos immersive experience, Jane now sees what is causing her discomfort. Taking her personal preferences into account, Jane and her doctor discuss treatment options that fit with her lifestyle. The doctor sends this information and any notes to Jane, so she has access to it after the visit. Jane will review this information and take the time to make an informed decision that is right for her. However, Jane received a lot of information at the appointment, and she wants to share the details with her family, but does not remember everything from the consultation. Fortunately, with Pathos, she has full access to visual details, visit notes, and patient education material from her appointment. She shares the important visit details with her care circle, and together they discuss the options to make the best decision for her lifestyle. We at Pathos Health believe that patient-centered care is the key to better outcomes and value-based care. This is why we have reimagined patient engagement from the ground up.
So we're approaching the self-insured employers and value-based care market. As bundled payers, they're strongly incentivized to reduce the cost of care, more strongly than anyone else, reduce the cost of care while simultaneously improving outcomes. And we're specifically focused in the musculoskeletal space inside of this market. The musculoskeletal spend in the US today is $300 billion annually. 20% cost savings represents a $60 billion untapped market opportunity. Our business model is we charge per patient, per episode, per year. So when you come into the system with a carpal tunnel condition, we charge up front, and we're with you from the day that you go into the system to the time you exit the system. We recently completed a successful trial, 50-patient clinical trial at Stanford Healthcare and their orthopedic clinics, where 90% of the patients experienced improved satisfaction, 80% of the patients had reduced anxiety. Doctors found that it improved efficiency inside of the clinic, and it was very useful as a shared decision-making tool. Where we're in use today. So we're in use in the Stanford orthopedic clinics. We're also in use in Stanford Oncology. We are about to formalize a partnership with the Occupational Health Center at Stanford University. We're partners with IDEO, and we're also part of the StartX community. Pathos Health is ready to change the way doctors communicate, treat, and educate patients in the clinical setting today. And at this point, I'd like to turn it over to you guys. Thank you. If there's any questions.
Great.
All right. Thank you very much.
Fantastic. So if it's not for companies like Pathos Health, oh, there is a question.
Hi, can you explain more about this bundled model?
Yes, so we developed a head-to-toe human body based on CT scan data from the visible Korean, which was a healthy 30-year-old male. Over the course of about 50 human years, we took that sliced data and built volumetric renderings of the human body. So there's about 2,700 different anatomical pieces. Oh, sorry, I thought you asked about the body. Yeah, so basically we charge per employee, a set price up front, and then the employee gets access to this, or for the patient, and the patient gets access to this inside of the clinical setting, and then on whatever device they want to consume it on at home as well.
Per diagnosis, it's per patient?
Per patient, per episode. So if you come in and you have multiple episodes, we may charge you for both. We're still deciding that. We haven't fully defined that. But when you come in for carpal tunnel, if you come in for CMC, arthritis, trigger finger, tennis elbow, we charge you at the beginning of that, and we're with you through your entire treatment journey.
Okay, before Tracy comes on, really quickly, that when you think about Pathos and what Pathos is doing and what is particularly exciting, at Doctor Consulta and the other clinic operations, it comes down to how much does it cost to open one of these clinics? This is like retail. It's like opening up a retail store. So it comes up, how can you do this cost effectively? And this is where I think the amazing opportunity that we're seeing here is it's going to be this the 15 to 20 to 50 types of technologies here that are going to make a difference. And that was an example of one. Okay, it's Tracy's turn. Oh, yes.
I don't know in America, but in the UK and other countries, most doctors and nurses are trained to tell you what's wrong. They don't engage with people. So they've got no idea on how to actually sell and buy engagement with people. They just tell you off or they tell you what to do. Even personal trainers are trained like that. So you might have the technology, but if the one-to-one discussion is led like that, you're not going to change behaviour. I don't know what happens in the States, but it's a great piece of software. So you've got to make sure that the people using it are actually got the skill sets to use it.
Combination of both. Tracy?
All right.
All right, tell them what you're going to do.
Okay. So it's great to be here. Thanks to HP and Vator. And I'm going to go kind of quickly because I think I'm eating up some of the time. So first of all, let's do a reality, kind of what's the reality today. So as Bambi said, right now this report just came out. 44% of all care starts in the emergency room. Yet only 13% of it is life-threatening. The average cost of care for an emergency room visit is $2,000. That's essentially $200 billion right there, but that's on the low side. So we have a massive information gap because we have incredible capacity in the marketplace that services that 30% of care that's ending up in the emergency room. There are more than 8,000 walk-in clinics available today across the market. They are literally like Starbucks in the majority of zip codes. We have all of those in our database. $1 billion has thrown into telemedicine, and they do 50 CPT codes. So there's this huge opportunity to educate consumers about where they should get in care. It's interesting. I mean, just yesterday talking to a digital healthcare company, and I said, oh yeah, CVS Minute Clinic. Oh yeah, where I get my flu vaccine. I mean, this is what everybody still thinks. They think it's just flu vaccine, and yet there's 100 different CPT codes, and they're even doing chronic diseases. So RocketMed is here to help close that gap. Right? We want to make it really consumer friendly for everybody to find all the Walgreens clinics and the Sutter clinics and the CVSs and all the urgent cares that are open 7 days a week, typically 8 to 8 or 7 to 8, do all of this type of emergency care. Understand the list of services. So there's two really important missing pieces, in my opinion, and I happen to be an RN. I've spent my entire career in the clinical world, and I'm super biased on bundling and the commoditization of healthcare. It can all be commoditized, and that's where I think it goes. So this is unbelievably affordable care. I mean, these price points are $50 for telehealth, $89 to $129. That's $20 billion if we did 100 million of those ER visits. So, I mean, we can really move the needle. So the recent announcement of Amazon JP, I'm thrilled, right? That is a conversation I think every self-insured employer should be asking themselves. Why do we get these payer platforms that we rent for a ridiculous amount of money that don't help our employees at all find all of these clinics? And they don't, because I do side-by-sides against United all the time because I happen to be a United customer. And when I show a self-insured employer, oh, by the way, you don't have to put your information in, your membership, nothing. You go on your chief complaint, an ear infection, a strep throat, whatever, and we deliver up brands. I think I heard brands up here on the panel, which I love to hear because none of the payer platforms are doing that. So you hear this, you see this clinic supposedly, but you don't really understand it because it doesn't say CVS Minute Clinic or Walgreens. And so now all of a sudden I'm like, wow, I've just discovered there's a clinic at my Walgreens that I go to, and I learn a little bit more. So the first step, I can't remember, somebody else also, it's these simple changes that I think we need to make, and then we start moving the dial really rapidly. So my relationship starts first with the provider. I want to be that aggregated model that gets you into a self-insured employer that you simply can't do on your own. So that's path number one, direct-to-consumer and self-insured employer. So we want to create and deliver a better consumer experience, help these providers do that, really extend the brand, give them data analytics, et cetera, so they go into other services, they grow the business, they continue to do more because they're incredibly efficient and super affordable. And it's 3 simple clips. You go onto RocketMed, you search on your complaint, because, oh, by the way, when you show up to a doctor's visit, there's a reason you're there. So let's start there. We've spent time on Google MD and discovered, right, we think it's an ear infection, and then we've got all these clinics, and then quickly we go in a Minute Clinic, and all the retail clinics showed price transparency. That's super exciting. And 2 pieces of integration from a consumer standpoint we're going to do in the next 6 months is we'll be integrating with Lyft and hopefully Uber for rideshare, and then wait time and get in queue. So just constantly thinking about helping these providers just extend what they're already doing into the hands of the consumer. Any questions? Yeah.
That's interesting. So how long before this becomes competition from United and others? Do you stay an independent entity, or is this part of a big aim? Who is it? I think Michael from Compass put money in Accolade.
Okay.
Is this the same thing? Are you a feature on one of those, or is this someplace?
No, this is going to be very different because, like, I'm talking to Exact Sciences for Cologuard, right? So at-home colon screening. So I'm going to move way faster into the innovation that's happening into the provider market than the payers are going to, right? And then I'm going directly to self-insured market. And I totally agree. A crowbar needs to be taken to it, and there's a gigantic opportunity to that. So, I mean, it's just the payment model, all of it. I've got a couple employers now that are looking. One's going to white label RocketMed, and it's going to be a powered by. So we're going to create a very custom network. They're going to pay these providers directly. Another one is a much larger employer with employees all over the country. And so ideally, we kind of just give them this network. And we also start giving them intelligence and data they don't have, as these guys aren't in the network, and they should be. These are great providers that your employees want to go to. And start really kind of bringing provider-employer together in a different way.
All right, we have to cut it off because we're on a tight schedule. Two great entrepreneurs, 2 great companies. Both these companies are raising money, guys. That's why they're here. Good, fantastic job. We want to also thank StratPoint, and we want to thank Scrubbed. They've been providing complimentary services to both Pathos and to RocketMed. And so now we're going to continue on.
So for this one, unfortunately, we have one of our panelists, Dr. Carroll. Hi, doctor, can you hear me? Patrick?
Yeah, I can hear you. Can you hear me?
I can hear you.
Great.
So we can't use mics, so we're going to project panelists. I think we can do that. And so I think he's all set up. I just wanted to mention that we won't have mics because of this Zoom we're doing with Dr. Carroll, but we have to handle someone else. So we are actually utilizing how to scale the future of clinic into telepresentation, which it turns off every other technology, which turns off every other technology. So I'll kick this off here. I think we'll have the screen of all the speakers here. We have Dr. Carroll over there. Dr. Carroll, you're on the East Coast, correct?
Close, Chicago.
Okay, closer than we are. So we wanted to have everyone introduce themselves, and Archana. Okay, so we are going to have all of our panelists introduce yourself. You come from a very amazing clinical background, to say, and then you're innovating the future of clinics. And one of them is joining from Chicago, but all of us are here. So if we can start introducing ourselves and how we are contributing towards the future of clinics. Because we could introduce you, but you'll do a far better job than us. So do we want to begin with Dr. Carroll? Yeah, let's do that. Patrick? Go ahead, Dr. Carroll.
Hi, Pat Carroll. I'm Chief Medical Officer at Walgreens, and probably more importantly, for 25 years as a primary care physician. Primarily practiced in Concord, New Hampshire. Had a panel of 3,500 patients, seeing 30 patients per day. And came away from that experience realizing that that model is not sustainable going forward. And so I've been at Walgreens now for 4 years. For 6 years prior to that, I had leadership positions both at a large medical group in Boston called Atrius Health, and then at Hartford Healthcare, an integrated delivery network. At Walgreens, I wear a lot of hats. One of them I oversee our retail clinics, and I'll go into further detail later on that, of what that business includes today. And I also work very closely with our healthcare alliance teams as we talk to healthcare systems around the country and payers around population health and value-based care.
Thank you. And I should say that Dr. Carroll planned to be here, but he had an emergency and a number of responsibilities that he needed to take care of. So, but we're grateful that he's with us. Thanks, Dr. Carroll. Andy? So Andy?
Sure. So my name is Andy Kurtzig. I'm the CEO and founder of JustAnswer, and we connect people with experts live 24/7 in many verticals, including healthcare. So in healthcare, we connect people in roughly about 8 minutes, 24/7. We have thousands of doctors answering people's questions. I wanted to be a doctor when I was a kid. My dad is a doctor, and my grades weren't good enough. So I've got the technology. My mom said that A students go to medical school, the B students go to law school, and the C students are entrepreneurs.
Hi everyone, Neil Parikh. Thank you again for having us on the panel. I am the Senior Medical Director for Oscar in the area of care delivery. What care delivery really means to us broadly is where we interact. Okay. More my time is up. It's where we provide direct or indirect care to our members. What that encompasses is our clinic, for the reason why I was invited here, but also telemedicine, our complex care delivery, and our concierge and member services. Prior to joining Oscar, or actually, I mean, still am a physician, still do practice, but was an internist and hospitalist at UCLA.
Hi everybody, my name is Shah Duffy. I am the founder and CEO of a company called Omada Health. You can think of us in a number of ways. One I'll talk about.
Carroll, maybe you want to mute your...
Can we have you mute here?
Yeah.
Yes.
Okay. Okay, perfect.
Very good.
So company's called Omada Health. You can think of us in a number of ways. One is actually as a hospital for early metabolic disease, and that's actually how we contract with our payer partners as a provider, no different than Stanford Hospital. It turns out that when you see the early signs of obesity-related chronic disease, prediabetes, other metabolic indicators, science shows that you can intervene in a very high-touch way through an in-person setting to dramatically reduce risk of progressing through the chronic disease continuum. So Omada's taken a lot of the foundational literature in this space, built upon it, and created a digital instantiation of this sort of program that is available to the masses.
Yeah, Nico Arcino with Kaiser Permanente. I'm the Senior Director of Strategic Partnerships. My colleague down there came to Kaiser and healthcare by accident 23 years ago. Wanted to be a doctor as well, an emergency room physician, and I found out that my hobby, computers and technology, was actually really my passion. I ended up changing workflow and redesigning within the ER, and the light bulb went out that I could probably change healthcare in a much different way. I've led the wireless strategy at KP, I've led digital health for the last 6 years, and now I'm strictly doing strategic partnerships, which is bringing tech companies like yourselves out here together with KP and seeing what we can do differently within healthcare.
I'm Nikki Sims. I work for Sutter Health. I'm the director of our retail program. So we worked as a team to come up with a really cool retail program to compete with all of the bright minds up here on this panel so that we don't lose all of our patients. And we're in the middle of a big expansion. We're really excited about it, and we've realized that as a giant dinosaur, we have to work really hard to be nimble and to try to partner with different tech firms and bring technology in to help our patients. Because now you're all consumers of healthcare, we all are, and we have to work a little bit harder to compete.
I'm Munjal, Shah, CEO and co-founder of Health IQ. I think I'm kind of the odd man out here. We don't have a clinic or any interest in building a clinic. What we do is we created a Health IQ test that measures not how healthy people are, but how health conscious they are. And we've utilized that, converted that big data into creating cheaper insurance, starting with life insurance for health conscious people, but eventually rolling out to long-term care, disability, and elements of health that we'll play around with kind of starting next year. But the interesting conversation that we were having that I think is, as you think about these clinics, 44% are not going, are starting in the ER because people just are ostriches in the sand about their health, and you can make the most easy to access clinic and they're just not going to go because they don't want to. But as with any new product, you always want to find your early adopters, and what we found is the health conscious are the few people who really like to find out more about their health. They will proactively get a blood test. In fact, when we do our life insurance applications, they frequently want their data and are like almost showing off with it. Like, oh, look, I'm a triathlete. You want to see my cholesterol? It's really great. And so, so I think there's and it's not just that; it's even the well-managed diabetics are kind of showing off. And so, I think there's an interesting conversation of don't just try to build a clinic for everyone, but figure out what's the right early adopter segment to kind of focus the clinics at, and maybe where to deliver it. Such as, maybe the clinic should be bundled next to the gym if the early adopter clinic is the health conscious rather than the clinic is bundled with the supermarket.
He is extremely relevant to the discussion, not only from a payment side, but because you're moving toward wellness and you focus on wellness. And I said this in the earlier panel, Archana and I look at the future of clinics as one, the access to care is changing, either telemedicine, on demand, or at these new clinics, but also the type of care, the type of services is changing, a la Omada Health. So maybe we can all answer this question, what are you doing? And Archana asked it earlier, but you guys just introduced yourself, so I want to get back to the future of clinics. So what are you doing either to increase access to care, more clinics, or changing the services of care to the consumer?
Sure. Well, I think we have a lot of clinics. We've been changing the model. I'll go into more detail about them. But we have 600 clinics, and I think with that, we've had to change the design of them. We have to reach out to what you need from a technical standpoint, from the point of your house, all the way to where you go into the clinic. We've introduced 14 different technologies that do that. It's more like checking in early, getting to there. It's different at the clinic. There's no waiting room in our new model. You just go there and we actually know that you're there. We have your identity. You can check in, you can know when the doctor's running late, and we'll also notify you when the room is ready for you to be seen. And there's a whole workflow behind it that we've created. So it makes the doctor, nurse, and not on a one-to-one basis, but more on a shared model. So we've been changing the way that we've been doing that in Southern California for the last 2 or 3 years, and now spreading that to the rest of the United States in 2020. Yeah.
Looking forward to, I'm a Kaiser person, so I'm looking forward to that. Fantastic.
One comment I wanted to make on this. So to me, access, and really the formula for access consists of a number of things. So how many visits and interactions do you have to have on a longitudinal basis? Because if you need your knee replaced, you may consider driving 3 hours. That may be a one-time thing. You'll do it. It's not ideal. You'll make that trek, and you have access to a knee replacement. In the space we're in, every single bit of data and body of evidence shows that you need so many touch points over a long, long period of time to have any clinical outcome and impact on someone at all. So there's really no choice in our world but to approach people and be where they're actually living in today's life that is in front of screens. So I think that when you're designing for what's the ideal system or touch points or experience for someone, I think it's important to always consider when you're thinking about access and what that actually means for the outcome you're trying to get, how many touch points you have to have longitudinally. And that can help you calculate exactly what you need to build to best serve a person.
So is that, a follow-up to that is that condition, you mentioned that it's condition dependent almost.
Well, I would say interaction dependent. We're in the chronic disease space, right? Yeah. So there's, all chronic diseases require multiple touch points over a long period of time, and to have someone come in every single time for a long period of time actually reduces access significantly, extraordinary amount. I think there are probably many other examples of that. You might imagine that, someone who's has cancer and they need persistent touch points for a long period of time. You work to get that intervention to their home or close to them in new ways. So I do think it's condition specific, but the key differentiator is the actual touch points and how many you need longitudinally.
In terms of access, that's the thing that I'm most proud about with JustAnswer is that we connect people with a doctor whether they have health insurance or not, whether they can afford a doctor or not. At 4 in the morning in a small town in Alaska, they've got access to a doctor anytime they need it.
And I think the idea of touch points is very critical, and we're probably a decent ways away from understanding all the touch points that are required to actually truly influence behavior up to the point of measuring a change in outcome. But it's important to understand that touch points take very different shape, and healthcare is still very much a people game. I think that's part of why this panel around clinics is here. And so it's understanding what can be done in the clinic, what can be done in a virtual manner, what needs to be done at the post-encounter aspect of it that can also be done either remote or in person. I think one of the things that we focused on at Oscar, and one of the questions is like, why is Oscar in the business of building a clinic, is we recognize that when you're taking a member-focused approach, that you have to be able to access members at all these various touch points. And the better that you can integrate them, whether you use telemedicine to then potentially route to a clinic, then back to our concierge services to be able to engage in any sort of follow-up, you are creating a more holistic experience that then hopefully maintains the engagement that ultimately allows you to potentially influence behavior.
So it seems like Kaiser has built the whole vertical from insurance to hospital systems to providers, and Oscar is kind of going in that direction.
We have one clinic. right up there again.
You just have one toe in the water right now. And it seems like, and Dr. Carroll is on the phone and on Zoom, it seems like the CVS-Aetna merger is kind of also going in that direction. So is that the future, how it looks like, of clinics?
Is that to me or Dr. Carroll?
Yeah, to you and to Dr. Carroll, actually. And can we unmute? Oh.
So,
he's talking.
Oh, he is. I'm sorry. Okay.
There you go.
Now we can hear you.
Okay. Anyways, You know, I don't comment on what their strategy is at CVS. I can tell you we have a very different strategy since I came to Walgreens around retail clinics. So when I came 4 years ago, we had about 450 clinics. And speaking to our kind of health system partners, what we realized is they really wanted to be more involved in the care model to create these access points. So over the last 3 years, in markets around the country, we've partnered with health systems where they come in and actually in our existing markets, hire our providers, bring in their EHR, and are actually really connected back to their system and back to their providers. It's really enabled them to expand scope of care beyond the 25 to 30 dose that are traditionally seen in retail health. That being said, we still run 160, 170 clinics at Walgreens that we run the care model. So 2/3 is run by health systems and 1/3 is run by Walgreens. And we also look at expanding those access points to care, and we have a strategy called a healthcare neighborhood, which has been very exciting to us. We've opened up 15 urgent cares around the country because we see urgent care as a lot of value in terms of an access point. Now, they literally can take care of 95% of the conditions that come through their door. And great access points, particularly the 3 that we set up in rural and semi-rural communities, it is a fundamental access point to care in that community. We've also set up lab services in our stores, hearing, vision services, and really a robust virtual health offering, including a partnership with New York Presbyterian, where in our Duane Reade stores, there are telehealth kiosks that connect to an ED group run by New York Presbyterian, the Columbia, and New York Presbyterian ED physicians. So we really look at creating a healthcare neighborhood that allows an access point to care and really trying to push that retail health model in collaboration with our partnerships to go beyond those 30 diagnoses, because we have to get into chronic disease management in these retail health spaces to really make an impact.
So as mentioned, we have 1 clinic. And the question often comes up is, you know, is the goal to go from 1 to 500? What is the point of our clinic at Oscar? And to be fair, to be honest, I think the way it started was more as an experiment, as I think probably many different initiatives happen within, you know, along the side of the panel. I think we wanted to know, we wanted to know exactly what it looked like from a member experience standpoint, being a very member-focused company. We wanted to understand how our technology was being used and absorbed, and the best way to do that is be able to interact with people in person. And at the same time, we wanted to understand what, when we work with our rest of our provider network, what does value-based care really mean? My sense is if you poll the people in this room, you know, we would probably be somewhere near some kind of central definition, but there will also probably be some significant variation around what everyone defines as value-based care. Whether it's just taking risk, or is it something that you're actually doing to influence a PMPM per member. And the best way for us to understand what value-based care may look like was to have our own clinic and give it a shot. And we think a large part of that value is driven by the integration with technology and being able to be better connected with the full stack of information and data that comes from other parts of being an insurance company. But then it's also being able to experiment with the type of healthcare that many folks have already spoken about, you know, a more holistic approach to a member. And then also figuring out what are the types of tools and approaches that we may be able to build there that we can then work in a more collaborative way with other providers that are part of our network to, again, create an improved member experience at any touch point, not just our own. And so that's kind of been our clinic strategy.
So I think we want to talk about, one of the reasons why we like to set up the panel this way is because we like to get the tech pioneers talking to the healthcare incumbents to see if there's some sort of synergy and match there. So I think Dr. Carroll had mentioned that he wanted to get into more into chronic care treatments. And so this question isn't for you, but more for Sean and then to Andy. Really, it's you're offering sort of a different service to cater to chronic illnesses.
Yep.
Do you see yourself working with a Sutter, working with a Walgreens, being on their digital shelves?
In time, absolutely. Sutter, we're as a customer, employees at Sutter are benefit eligible for Omada. We work with Kaiser in many regions. I think all actually. Where we're referred individuals, and I think the exact same thing holds with Walgreens and retail clinics. I think any moment, I would go even above like the clinical infrastructure. Any moment where someone's found to be a good candidate for a program like Omada's and they're covered, we'd love to take advantage of it. Now, to really create models that work for that to happen, we have to have sufficient market access and coverage in certain areas. Because if there's like a throughput of 1,000 people coming into a retail clinic or into a PCP that's still largely fee for service, and only 100 of those would be reimbursed for Omada's program, it makes it very difficult to influence at all prescription behavior or referral behavior. So Omada's on the mission, and in the long arc of our company, to get the majority of insured Americans in the country in a place where we're in their medical policy, and they can be reimbursed should they be clinically a fit. And there's actually a couple of states where we believe we're just at the tipping point where we can start to explore these models. So that's how a Walgreens and Omada could work together.
So the other question kind of related to that, and I'm going at Omada again,
sure.
Is we have seen the transition in physical therapy, for example. It's a direct access model. People can self-refer themselves. For physical therapy, they go to OBGYN, self-refer themselves. Do you see Omada getting to that point in which people can self-refer themselves to an Omada, which could be a digital therapeutics that they can actually buy off the shelf of Walgreens and be reimbursed? Are you going in that direction?
We're not pushing hard at it, but it's conceivably possible. I mean, there's a pretty good way through a risk screener that's validated against the CDC diabetes data set to determine if you're likely to have early metabolic risk, and you can use that to determine if someone might be a clinical fit. So I think as coverage evolves, that can be possible. We are in a situation in the country where if you look at prediabetes alone, 90% of people who, if you were to test their blood and they would find out they have prediabetes, actually don't know it. So you really, as much as you can pray that people are going to go into their primary care doc and get screened, you have to find alternative ways to really have broad impact.
I think we mentioned Walgreens so much, we really should have Dr. Carroll. But I do want to, Dr. Carroll, I'd like you to respond to two statements or answers, because I want to ask Andy. Andy provides, Walgreens wants to be on the front lines of access to care, and you provide sort of this slew of physicians. So is there a way, and I'm sure they don't have as many physicians as you have access to, so is there a way to work with them? Do you think there's a way to work with them? And then Dr. Carroll, I'd like you to respond to whether you could work with both of these services.
Absolutely. So I think many people here, are big believers that healthcare is moving online and getting much more digital. Not everything, but certainly telehealth and talking to a doctor is going to move more and more online. People are going to expect to get that digitally. And as Casper the Clerk said earlier, it's a tough business, the telehealth business. I'm sure you've seen lots of companies come and go into space. And we've been doing this for almost 15 years now. And we're not trying to be a billion-dollar company in the healthcare field. We're in other verticals, and that allows us to compete and to be be really good at this one thing. And that one thing is connecting people with experts, and in this case, doctors. We're very good at that. We've done all kinds of cool things to make that efficient, both cost efficient as well as efficient for customers and for the doctors. We've got chatbots and a bunch of cool things we could talk about. But at the end of the day, we're an ingredient for anybody who wants to have that thing plugged into whatever else you're doing. And we don't have ambitions of taking over the world in healthcare. We just want to do that one thing well. And happy to do that any number of ways, including being $30 on the shelf at Walgreens, if that's what it takes.
So Dr. Carroll, do you want to respond to, can you integrate with these two services? Do you think they're appealing and useful? useful.
Yeah, absolutely. So, I point to one of our partners in the Pacific Northwest, Providence Healthcare. And what we've done with them is working with Aaron Martin and his group, such that if you're in Seattle, you can go on the Walgreens website, and if you were looking to try to access care or questions on the Walgreens website, there'll be a direct link right into the Swedish website. And Swedish actually offers you a visit with price transparency to one of the retail clinics that's located in a Walgreens. You can also get an appointment for urgent care. You can get a home visit, where you can have a virtual visit. So we think that the virtual care is absolutely a big part of this healthcare ecosystem. And our view is we want to partner with health systems such that in the MSAs that we're in and we partner with the health system, we want to provide that link from a Walgreens website with an app that's been downloaded 50 million times right into that health system's access points, including virtual health.
Should we bring these other guys in here too? Maybe Sutter, Nikki, and Nico, you could talk about what applications or services, new offerings you're looking for?
Sure. So we're really finding there are a lot of patients now that don't want to have a primary care physician. They just want to find care where it's convenient for them, and that's really difficult for health systems because how do they reach those same patients in a really convenient way? And it's moving more and more in that direction. So we're trying to offer a really low price point. I think it's difficult. Insurance companies have made it really challenging for us to know what we're charging. We're also diving into video visits, and we want to collect as much payment up front so we don't have bad debt down the road trying to serve these patients. But what happens is the insurance is so complicated. We're really looking for some sort of a system that can help us understand what benefits are available to patients and what's left on their deductible. The process to go into that is so tedious, and we're spending lots of time on websites or through passport systems and Epic that are just good enough, but not really good, and they're not incredibly accurate. And so it's a big void for us to collect any payments up front. So that's one piece that we've really been looking for. And also, one of the things that's great about being in a healthcare system is that we have all of these opportunities to connect patients to specialty care. We don't have to do it all. We just have to do what we do really well. And I think we do that, and we can focus on the consumer. But when we want the patients to stop going to the emergency room and come to the retail clinics, or if it's just a little bit above that and we want them to go to an urgent care, how do we communicate that to our consumers? And I think it's great there's so much competition, but we've also created a lot of confusion for each other. Where do you go when you have certain ailments, and how can a technology help educate our patients where they're supposed to go? I think we can find some that can help with, especially a large health system where we're saying, okay, this patient's coming in and they have these particular ailments. The first step for us was determining what we wanted to be when we grew up. So I think we figured that out. These are our metrics of care. This is the continuity that we want our patients to follow through. And now it's helping the patients navigate that. Now that we've determined what that looks like, and we're still waiting for something to come up.
So I have a question based just kind of tail end of that. How do you, in this time of One Medical and IORA and Forward now, compete with that? So they're directly reaching out to the consumer, saying 24/7 access, concierge. You can talk to your doctor anytime. So JustAnswer. How does that compete with that kind of access that the patients have? And then how does Kaiser and Sutter compete with that platform or those platforms that are providing that 24/7 concierge kind of perception or reality, whichever one you want to answer?
Well, we already provide 24/7 service.
Yes.
So, but I mean, I would say beyond that, I mean, we've been doing, I think, we've been a target for the last 6 years in care quarters in Southern California, doing kind of like, for whether you're an employer or employee at that facility, so you don't have to leave the site, making it convenient for you. We've been in Bartels up in Washington, trying to, and where you can actually have whether you're a member or a non-member, actually get a visit for minor injury or illnesses, and you check out and you pay directly through them. And so we've made it easy from a website through them, or if you're a member, kp.org. We're doing Care Essentials in Portland and growing that model where it's more of a convenience strip mall, anywhere local to your facility for convenience. So that if you don't want your primary care, you don't want to drive to a facility, it's right there at the mall or the shopping center. That model is going on all the way to the RAD clinic, or the new design that we're talking about, where it's strictly for our members. And that you get the digital experience across 14 technologies and above that. I think from whether it's precision medicine or trying to get into the other realms of what we want to do, we're already partnering with people like Omada, and we're trying to figure out how to get there before, so we can identify. And then after, we're doing things where turning more paper and phone-based encounters for rehabilitation into virtual ones, so we can actually scale. So if you have a heart condition, or you've had a heart attack, something serious, we can get you really healthy and really soon have access to you in a mobile or wearable way. So there's a lot that we're doing to try to spread that, and it's not just one thing. I think you have to tackle it from many, and there's so much more room to partner, because we will never be able to build as fast as healthcare is needed in this country.
Yeah, I think we're really similar. I think the only thing I would add would be making sure that the patient experience doesn't feel so much like healthcare. We want it to feel so much better when they're entering these sites, and we've all had that healthcare experience. It feels kind of like you're at the DMV sometimes, and we're trying to change that. And I think there's some really cool technologies that help with that experience. Checking in is great. How do we make that experience more seamless for patients? We need so much information in our EHRs for those claims to get paid, but how do we take that burden off of the patients? That's really what we're looking for. And then when they're coming into the site, doing different types of check-ins so that the patient doesn't feel like they're going through this cattle line, that they're relaxing and they're sitting on nice sofas and they're looking at art, and it looks more like a gallery or a spa than it does an actual healthcare setting.
And that's where we bring Munjal in.
Yes.
I think and I'm Kaiser, by the way, but you could use a gym and a spa.
It's coming.
But I think companies like Munjal's will actually drive you to change your services, hopefully, because Munjal's company, Health IQ, is really merit-based healthcare. So I'm curious, how do you get these clinics, and if you are healthier, your insurance comes down. I love that. And so I'm all for it. And we have 10 minutes, so get your questions ready if you got questions. So my question is, how do you get these clinics to, because they all need insurance to go to your clinics, how do they integrate with your type of merit-based insurance solution?
Yeah, I mean, the way I think about it is, we believe over the last 20 years that America's really a tale of two cities. That while most of the country's gotten less healthier and possibly less engaged with their health, there's actually about a 50 million group of people that's gotten more engaged and aren't necessarily all healthy. They can also be what I call the unhealthy health conscious. They can be a well-managed diabetic, etc. And that while we think about kind of products and bring these clinics, and what I keep hearing is kind of a, we will build it and they will come approach, rather than a, what's the exact use case that's going to draw people into these clinics that's going to make it. Like, you joke that it was, the person who was talking before, is like, I go there to get my flu shot. Well, but that's a very clear use case. That people were okay having a nurse or a nurse practitioner do, but they're like, I don't know, I'd rather go to see a real doctor than a nurse practitioner. They don't realize that a nurse practitioner has the word nurse in it, but actually has as much training or a lot of training. But nonetheless, I think that when we look at the health conscious, there are numerous things that these engaged people want to take care of, and you can shift them easier than you can shift probably anybody else to an alternative. They want more frequency, they want more testing. They're interested in kind of getting their A1C tested more frequently because they're trying a new diet and they want to see if it made a difference after 3 months. Versus everybody else will be like, I'm only gonna get my A1C when my doctor makes me do it again, and then it's too late. It's become 7 or 8. And so I think that what nobody seems to be doing is really looking at what are the exact use cases that I can move to these clinics first to almost create the draw. Once in, I can kind of expand the other CPT codes I handle, but what are the exact use cases to what exact audience? And it's amazing, like in all business, you're always like, who's my customer, what's his need, what's the use cases, what's that? But every time I hear people talk about clinics, I hear this like, we're going to build this thing that's going to handle it for everybody and move everything away from the ER, but I don't think that's how consumers change behavior. I think you have to teach them kind of one use case at a time. Oh, you can come here for that. Well, now you can come here for that too. Well, now you can come here for that. And then you habituate, habituate, habituate. And then you get the shift you want in the dollars and the behavior. So you're not just running off to the ER every time or running off to kind of a more expensive solution.
So I have a question on that. So you're almost sitting between the health systems providers and the patients on both sides.
The engaged patient.
And engagement, yeah. So the health IQ determines your healthy behaviors and health consciousness. So it's merit-based and also risk-based insurance. It's almost like if you don't do things right, you end up paying higher. So there is that penalty kind of built into that. But there is a reward built into it. It's this, that if you do things right, you would get things going.
There's not a higher one in the health conscious part, but I'll explain that in a second. Yeah.
Okay, so two questions that I have is, what kind of medical groups and networks will be in network for you? And how would you measure that?
Yeah. So to clarify, we don't do cheaper health insurance today.
Okay.
We do cheaper life insurance. We'll roll out soon long-term care insurance, disability, et cetera. We don't do health insurance because formally under the Affordable Care Act, you cannot differentially price health insurance. Right? Pretty simple for more health-conscious people. Our discounts are primarily driven around you scoring well on the Health IQ test. What the Health IQ test effectively measures through a very kind of innovative system we've built, but what it really measures is we've basically figured out how to find the people who care about their health. Like, even a question that isn't necessarily based in science, like, do you know this about Ayurveda? That part of Ayurveda may not ever have been proved in science, but if you're a Caucasian male and you happen to know a lot about Ayurveda, you didn't learn it from your family, like you actively went out and tried to seek that information, which means you care about your health regardless of whether that information is accurate or not. And so what we've done is we've just found a way to find all the people who care. That doesn't mean they're all healthy, it just means they care, right? In fact, the biggest discounts we can give in the life insurance area are actually to well-managed diabetics and others who are chronically ill, but managing things super well. They're actually the most mispriced because the system assumes that kind of they're going to go uncontrolled for years and matriculate from, taking metformin to injections to, then all the risks inherent with that, and the probability of death goes way up as soon as you're injecting insulin, right? So, but we're able to say, you know what, this is the person who's not going to matriculate, or is going to matriculate very slowly, or even reverse, because they're going to end up losing 50 pounds.
So in that case, the Omada would be a discount for them if they are enrolled with Omada?
Well, we haven't even gone to that level yet. For now, we've just found the people who have already taken responsibility and identified them as a group, and giving them cheaper policies and lower premiums. The next step for us is to try to bend the curve even more, because with the engaged patients, we can probably bend the curve way more than we can with an unengaged patient, by a lot. And so then we say, hey, you know what? We're willing to actually spend X $100 a year on them, because if we can bend that curve further, they're going to have lower mortality. Lower mortality is going to result in a lower claims rate. Lower claims rate is going to make it cheaper, and then we can actually translate some of that back into the premium cost. We also believe we can do some of this for morbidity, even though we don't technically have a morbidity table that's as accurate. A lot of morbidity costs are end of life, so to the extent you have a better mortality table, you end up having a better morbidity table. Not fully, but partially at least. And so, but I kind of keep coming back to, our approach is a customer segmentation approach at its core, right? It says that there's this interesting group of customers nobody's thought about, nobody's thinking about, that you can handle differently, you can get them into your clinics differently.
We have 4 minutes. Maybe we should open it up to, I'm sure.
So what do you
Matthew has a question. Oh,
I'm sorry.
What question would be strong?
Okay.
So this is a generic comment, but Peter Grant, who emails out a bunch of stuff about health policy, emailed while this was going on, and there was an article from Peggy O'Kane in Health Affairs, which just said that primary care spend has gone down by 6% in the last 5 years. So despite all this great stuff, and we've had, you guys don't have Aura here, but all the great primary care networks are saying, spend more on primary care, you'll save it down the line, and all those savings. Very good, hasn't shown up in the numbers. Now, if you look at the panel we have here, not to pick people out, but Patrick, you at Walgreens have gone away from the Walmart model of saying we're going to offer it all, and you're now helping other health systems. Nikki, you're doing a defensive measure to make sure that Sutter can keep its high-performing, expensive, very expensive hospitals keep going. Nico, yeah, you guys have got a classic primary care model in Kaiser and forever, but it's never really spread out of California and Hawaii and a couple of other small places. And everyone else is struggling. So I'm with Scott, who said that Amazon's going to change it all. I've been doing this for a long time now. The Southern California primary care groups in 1992, 93 all said they were going to change the world and do the same thing. And it's never happened. So I love everything we're saying. It's all great. We're not sustainable at 20%, but what is going to change the dial seriously on getting to a new clinic-based primary care system that is going to be radically different? Who's got an answer here that's saying, yeah, but Scott is right, in 10 years' time it's going to be different?
Payment's going to drive it. Payment, it's going to be payment because you are actually removing, as the benefit plans are moving more towards the patient paying for it, they will ask better from the primary care.
I hate to say this, but there's a small payer called Medicare. There's a certain program that sure doesn't know if they have yet to pay for. And that's a tiny little program. Right. So I can't believe you didn't say that when you're talking about employers. So say something about Medicare. And,
it's funny. I mean, Medicare's still at the 5-yard line. It feels like the last couple of years it's been this case to pay for diabetes prevention programs, even though they've done in-person studies looking at both clinical effectiveness and actually pretty dramatic economic outcomes. I think they will get there. There's actually some odd regulatory quirks that made it so they couldn't make that change, even though there was pretty broad support with CMS. But I think they have to, along with a lot of the world, just bring their brains toward what it means to be digital and realize that, okay, just because it has the word digital, it doesn't mean fraud and abuse. You can have auditability. You can track millions of data points to ensure that is a real person in your program and enable outcome. I mean, we have a year-long clinical trial with 65 plus that we did really on purpose to show convincingly that our program could work in that population with Medicare. Not only that, we're willing to say to CMS, I mean, we're saying to CMS, you don't even pay us for, we'll charge on the outcomes that we've shown in our trial here. So, in time.
I would have to say, the spending has gone way up, just not how you're measuring it. If you look at consumer spending on probiotics and consumer spending on organic and consumer spending on all these other, let's call it self-care elements to do preventative work to avoid these chronic diseases, and you add up all those, probably gym memberships in the country has gone up significantly in the last 10, 20 years. And so if you add that all together, it's actually gone up a lot. It's just not being paid through payers necessarily. It's being, and through kind of providers, it's being paid through consumers in an out-of-pocket way. And nobody's totaled that all up.
But the only point of it going up in that area is to get it to go down in the other stuff, right? The reason that Sean has a business is he believes it's going to go down somewhere, there'll be fewer
well, or not grow as much as they could have grown. Let's take it outside.
I have one other question. I'm a member of Project Baseline, and we're going more to genomic care and all that, and you're going to find stuff when you start looking at it, and this is more the higher end people, but you're going to start finding it. That's going to raise the cost too, in a way.
She's the boss.
Well, and I think if this is to be continued, because I think we are having a great conversation, we're just kind of almost starting to touch the tip of the iceberg. We haven't even arrived at the iceberg yet, but I think we all kind of in our universe contributing towards the future of clinics, and in our universe creating digital therapeutics that can potentially be incorporated into these futuristic clinics that we are creating. And maybe one person, or one Kaiser, or one Sutter, or one Oscar doesn't have to do it all. Maybe we can all collaborate and create the healthcare universe that can have this futuristic clinic. So with that, because our time's up, I would like to thank each and every one of you to join, who has joined here, participated, or just listened. Our panelists, esteemed panelists who took time to come here and spend time with all of us. Dr. Carroll, I know that it's possibly 10 in the night, so I appreciate you joining via Zoom. So thank you so much.